Started at another webinar. Today we thought it's very important, and to give this talk we have none other than Dr. Jagadeesan, who's professor in radiation oncology. And I bet, like how we heard Prashant Ganeshi is also, Jagadeesan is also so practical, very sound theoretical knowledge. You'll agree to it at the end of his talk. He'll be talking on newer radiation techniques for treatment of gynecological cancers. He is one of our cancer clinic members who's regularly there. We just wait for these people, and it goes on. All the tumor ports go on very well because of them. They're all my students, but still you feel proud. Not just my students, obviously sir's students, but we feel very proud to have them to give such talks. Over to you, Jagadeesan. So you would like to say some few words before we go ahead?
No, nothing. I welcome Jagdish. I welcome. I know him well. In previous meetings also, he has given talks.
Thank you very much, ma'am. Is it audible now?
Yeah, so we welcome all the participants here, all the delegates, and of course, Veena's efforts always.
We welcome
Love for
Abraham PDK also. Welcome.
Dr. Abraham has joined.
Hi, sir.
Sir. Good evening, sir.
Good evening.
Nice to see you. So, Dr. Abraham is former HOD of Gynae Oncology at CMC Vellore, and now sir is working. I always forget the name of your
Naruvi.
Supposed to be fragrance. I didn't know that word in Tamil.
More than that, sir is a very good friend of us. We've known him almost for more than 30 years now, sir. I mean, at least me, sir, Habib sir, and Dr. Abraham must be knowing even more. So welcome, sir. Welcome to you, and welcome, Dr. Padma. Jagdishan, you can go ahead.
All right.
Thank you.
Thank you, everyone. And thank you, Lada ma'am and Dr. Veena and Professor Saeed Habib sir and all the other dignitaries who are available in this group. Without much ado, I'll jump into the presentation. Let me just briefly share the screen. I know my son might be coming in the background. Please pardon for that. I have told him many times. All right. I hope the presentation
is it's seen.
Yeah, it's seen.
Full screen now.
Thank you. So I have been asked to present on the newer radiation techniques for treatment of gynecological cancers. So I'll try to be as precise as possible. And before I jump into the details, I'll just give an overview of what is standard. And then in just 2 or 3 more slides, I'll cover up the newer techniques or advancements in radiation technologies. So when we treat as radiation oncologists, we treat majority of the focus goes on to treatment of uterine cervix, followed by endometrium, and then vaginal and vulval cancers, and predominantly most of them are squamous cell carcinomas, except the ovarian and the endometrium. So there is very limited role of radiation in ovary, especially in the curative management. So we'll not focus much on that. So coming on to just to have a idea about the numbers. So this is the total number of cancers treated in the department. So there are a total of around 3,500 cancers registered in 2023, out of which you could see 469 were contributed by CS cervix. We'll go to the next slide to see the other distributions. Among all the gynecological cancers, except the cervix I have removed out. The rest of the cancers, the number distribution is displayed here. So you can see we had seen around 50 endometrium. Obviously, the numbers may be lesser because this is caught using the database website which we maintain in the department. It may shoot up by another some 20-25%. So it was 50 registered in 23 and 19 of ovaries, which was seen in the radiation oncology. Of course, ovaries are a lot in number. 19 were referred to our department for certain specific treatment scenarios, and few carcinoma of the vulva and the vagina as well. So this is the numbers which we are looking at in our department. And to just give you an bird's eye view about how radiation has been used up in the treatment of all gynecological cancers, we can just look up chemoradiation treatment forms a standard backbone for the treatment of all stages of cervical cancers. And we have an expected 5-year overall survival of 54%, all stages put together. Obviously, the earlier stages will have much better survival, while the later stages may have a little lesser than around 40% and below. In endometrial cancers, the majority of the radiation treatment is in the adjuvant setting, where we offer radiation for the prevention of relapse. So obviously it reduces the loco-regional relapse, and thereby it improves the disease-free survival. When it comes to vaginal and vulval cancer is almost akin to cervical cancer in the treatment perspective. So we can go with either surgery or radiation, and chemoradiation is almost in similar lines to the management of cervix cancer, or we could even attribute to similarity terms with carcinoma of the vault. So we expect almost similar overall survival for the squamous cell carcinomas. So this survival is lesser in vulval cancer when compared to vaginal cancer, because vulval cancer traditionally are quite similar to the male counterpart to a penile cancer, and these two cancers have got very poor outcome, and they're quite aggressive in nature. And the moment they spread to the nodes, it becomes very difficult to treat and cure them. And obviously in ovarian cancer, there's a limited role for radiation. We are reserving it only for an isolated relapse despite multiple lines of chemo and other surgery. If there is an isolated pelvic relapse, that's the only setting where we jump in and shoot radiation to that. So with this, I'll just give you an outline of what is the standard treatment technique we are following precisely. And then we'll move on to a few more slides of the advancement in techniques. So typical radiation course is usually comprised of an external radiation treatment called the teletherapy or the EBRT, and it sometimes includes the brachytherapy component as well. So the external radiation treatment will be over a few weeks, usually 5 to 6 weeks, and brachytherapy is usually offered in multiple settings, like once in a week for 2 or 3 settings. So what happens in an external beam radiation setting? A patient, let's take up the classical case of a for discussion purpose, we'll look at a cervical cancer. Patient comes up with, let's say, a stage 2B cervical cancer, which is quite the commonest stage of presentation. So in such patients, after the diagnosis, evaluation, everything is completed, they're going to be, once we plan the patient to be treated for a chemoradiation, they are simulated in this CT scan. So this is a special purpose CT scan, which is not used for diagnostic purpose. We're going to use it only for treatment purposes. Once the image is captured in our department, we're going to mark the tumor location and then give some extra margin for it, so that even if the patient moves during treatment, we can accommodate that missing out of the tumor. So that job is called as contouring in our departmental terminologies. So contouring is done to mark the tumor site as well as all the important organs around. So obviously the pelvic organs, bladder, rectum, sigmoid colon, bowels, and even the head of femur, all these forms important organs which we need to avoid excessive radiation. So following this task, what we do is we let the computer decide. Nowadays, we are letting the computer to decide the best angle or the best direction to which shoot radiation, and accordingly, we start to calculate the doses, expected dose. So to visualize it, we use usually a color format. So usually the highest dose regions are colored red, and the lowest dose regions are technically not colored, but then for visualization purpose, we'll color it with light blue or dark blue. So as you can see, this is an IMRT plan setting where the doses are heavily concentrated onto the nodes. So this was an IMRT boost sites, and then it is subtly thrown onto the nearby zones. And the bowel bag, which is again contoured here, bowel bag is technically peritoneal spacious. We are trying to preserve reduce as much of radiation to this zone. So this is one of a typical example of how we treat cervical cancers with radiation. So obviously in this external course of setting, we also add other treatment. Maybe the entire 6-week course is usually split up. So when we prescribe, let's say 50 gray, we split it up into a fraction of 2 gray per fraction. So each fraction is delivered over usually once in a day. And in fact, until now, all the studies have shown benefits with only once in a day. We have not done any trials on twice in a day yet, unlike in lung and other cancers where it has shown some benefit. because of usually we have avoided all the community has generally avoided it because of excessive toxicities when we go for 2 fractions in a day. So we stick to 1 fraction of 2 gray in a day, and we are going to split it into 5-week schedule, and each 5 fractions are given once in a day for 5-day, Monday through Friday, and this is the standard pattern followed. So we also add some drugs during the course just to ensure that the radiation killing effect is enhanced with those special drugs, which we call as radiosensitizers. And coincidentally, most of the anti-cancer drugs that are used in to treat cancers are also a good radiosensitizer. So that's how most chemotherapeutic drugs typically, in fact, the only dominant drug that is mostly used in almost all radiation oncologists radiosensitizer is a cisplatin. So that's an universal drug which we use. So that is the part of the external beam radiation setting. So this will usually be followed by a brachytherapy setting. So the brachytherapy setting involves usually placing an applicator like this into if there is an intact cervix, if it's not an operated patient, if it's a radical setting, we're going to insert this tandem into the uterus, and we're going to keep some plastic stuff like this. So technically what we wanted to do is we're going to keep radioisotopes into the target zone and then let it stay for some time and expose the tissues to radiation and remove the radioactive source. So this, over the years, it has evolved into such a scenario that we keep a hollow tube priorly into the target site, which is usually the uterus and the cervix, and which is completely devoid of any radiation. So our job is, inside an OT, is to place all these applicators in the right place. And once we do that job, we then take the patient to the treatment room where we connect the other end of this applicator to the treatment, the machines called as brachytherapy machines. Sorry, let me just go back. So brachytherapy, once it is connected to the brachytherapy machine, we are going to, the machine is going to push the radioisotope into the tube. So this is the best and most safest method of delivery of brachytherapy as of currently in practice. So this way, none of us are going to stay inside closer to the treatment machine or closer to the patient when the treatment is on. So this second part is called the brachytherapy, which is an important and integral part of radiation, because the beauty of this is we're going to throw as much highest dose right into the target without any exposure to any other organs. As you can see, if you want to shoot radiation to the cervix part around here, so we can just let the source stay in that, which is usually controlled by the computer, and then stay there exactly near the cervix part for a few seconds or even up to 10 to 20 seconds, through which it can deliver almost 2 gray or up to 5 gray or even 8 gray in a single shot. That's what happens in brachytherapy setting. So this image is actually a cut section of a linear accelerator. It will take more time, so I will try to skip this part for more explanation. All right, so evolution of this technique. This is the standard technique followed currently, but how it had evolved before is, previously instead of using a CT scanner, we were actually doing simple X-ray images and capturing it, and we are trying to design an anteroposterior portal like this. Define a rectangular box through which we intend to deliver radiation. All right, I think somebody is trying to draw something, annotations on the screen, I suppose. Dr. Sindhura, you can remove the annotations later. So this picture shows a age-old machine of telecobalt, which is very less practiced nowadays, but it was a robust workhorse in the last few decades almost. So it was helpful in delivering the external radiation. So this is a setting where the patient lies on the couch, and the radiation cobalt source is what is throwing up the radiation. And this is the direction, we choose the right direction to deliver radiation. So this is of course an head and neck patient with a cast on. But for a pelvic cancer patient, we'll have a cast on the pelvis, and the radiation beam will be shot onto the pelvis. So this is our linear accelerator. The previous one, let me just go back. This is not our linear. This is not our cobalt machine. This is another institute from AIMS, which they have decommissioned now. So this is our currently. It had worked for almost a decade, and it is going to get replaced by another new one. So this is a linear accelerator. It's a modern linear accelerator, which has all the technical techniques, like we can deliver IMRT, VMAT, IGRT. Even whole body radiation can also be delivered with this machine. So with this, we are treating most of the cervix as well as all the pelvic cancers, even head and neck and breast cancers until now. So yeah. So I've told you about how to sensitize the tissues to radiation during the course. So traditionally, we have been using cisplatin. There have been multiple trials to cover with carboplatin, especially in patients where they have renal problems. So we can't deliver cisplatin. So we go carboplatin. And there are concurrent trials. Even in our own department, we have tried paclitaxel in a concurrent setting. We didn't get any change in the tumor outcomes, but then we got more toxicities. So we didn't continue the practice of delivering concurrent paclitaxel. So obviously, 5-FU, capecitabine, gemcitabine are all nucleoside analogs, which are also potential radiosensitises, but they're not proven to be any better than cisplatin. So we don't use any of them. Recently, over the years, bevacizumab picked up pace, not as a concurrent setting. It was useful in the adjuvant setting or in the palliative setting of cervical cancers. But what has happened, what I would say is that a major change nowadays is use of immunotherapy drugs along with radiation or timing with before and after radiation. So it has been found that radiation is destroying the tumor cell and exposing all the antigens out. And these antigens can be detected by the immune cells in our body and therefore it can initiate an anti-cancer immune reaction. But traditionally, anti-cancer immune reaction is defunct because of a so-called PDL1 pathway. So that pathway blockers, when used, can effectively revamp the anti-cancer immune capacity of our body. So what I'm trying to say is that radiation and the immunotherapy drugs work hand in hand to expose the antigens out of the closet within a tumor into the immune system and thereby initiate an effective anti-cancer immunity in our body. So this, of course, pembrolizumab has not been useful in a concurrent setting, but has been proven to be useful in an adjuvant setting in many other cancers, especially esophageal cancers, and not just pembrolizumab. This scenario is successfully used in lung cancer with durvalumab. So that is just to give you the list of drugs that have discussed. So this is just to highlight again, this is the brachytherapy machine, which I had told, and these are the applicators that can be inserted into the cavities or wherever we want to shoot radiation at. Of course, there are different types of applicator design just to accommodate different shapes of the vagina and vulva. And if it is a post-operative patients, technically we won't be using this tube is called the tandems. We won't be using it. We'll only use this ovoid shaped boxes or rectangular boxes or different cuboid boxes. So we're going to use that to deliver the radiation in the form of brachytherapy. And so these are again different applicators which can be used when, of course, let me briefly go back. So when you use this typical applicator, we are not able to throw more dose to the lateral part of especially into the parametrium. Supposing we have a residue, even after the completion of external radiation, there is residual disease stuck on the parametrium. With this brachytherapy, we will only be able to deliver dose to the cervix and immediate vicinity within 2 centimeters of the central line. That's why, in fact, traditionally we used to even define point A as something 2 centimeters away from the midline at and above the level of external os. So that concept has slowly been replaced. I'll just briefly explain a little later with the new volume-based treatment concepts. So what I meant to say is that with these applicators, we can these are special invasive things which we will place into the patient's body. Of course, if you can see the right lower image, there is a central tandem over which we are running a plastic obturator, and there are multiple invasive needles that are inserted right into the tissues. So they don't, until now, the intracavitary brachytherapy used only a applicator that stayed in a natural space. There was no invasion into it. So on the left side in the X-ray image, if you see, the central tandem was not piercing through any of the tissues. It was staying in the natural uterine cavity and the vagina. So vagina was holding the cuboid boxes and the uterine cavity was holding this central tandem. So now over the years, what has happened? Of course, it's not a new technology. People have been using it. I'm just giving you the picture on what changed over the years. So these special needles were driven into the sites to shoot, to try to reach the parametrial disease if it is left out in such a patient. And through that means we can deliver more dose beyond the center, away from the point A, even to the so-called point B. We can even throw up to doses for point B. Of course, in this age, we are no more using the point A and point B reference. We will be using, since we are taking routine CT scans, we can directly mark the region what we are going to treat, and then we can put in a needle into that zone. Any additional area which is not covered by this brachytherapy can be covered with a needle. This is another utilization of needle brachytherapy, where we are trying to shoot radiation onto the surface of the skin, which is a vulval cancer, onto the inner tissues as well. So there are multiple catheters inserted into the vagina and the vulva. Thereby, we are trying to cover. It's a periurethral disease, so we were not keen in operating the patient. So we went ahead with the radical intent treatment. We gave external radiation, and then we are boosting that region with further needle brachytherapy. Obviously, these are not hard needles; these are soft needles. So the technique remains the same. After the needles are placed in the OT, we are going to bring the patient on the right side. You can see we have brought the patient to the brachytherapy room. We are connecting the catheters onto the machine, and we'll come out and then monitor the patient through the camera and switch on the machine to deliver the isotope into each of the tubes. So that's how a typical brachytherapy session is conducted. If not for this interstitial, we would have had a simple intracavitary brachytherapy, which we use it in cervix cancers and even post-op endometrium. All right, so this has been the standard. So what has actually changed over especially in the last 1 or 2 decades? So what could have changed? Obviously, since we have started using linear accelerators, people have done, although IMRT has been in vogue, but it was proven to be less toxic when compared to a standard 3D CRT, so-called 3D radiation treatment. Through the trials, of course, there are a lot of Indian participants in this PARSA trial. So we had good data to prove that when we use IMRT technique over a standard 3D conformal technique, or even a cobalt-based treatment, it can be less toxic. At the same time, we didn't get any improvement in the outcomes, but we definitely had the same outcome with lesser toxicity. So this IMRT has completely replaced the routine standard treatment. And in our department, we use a modified form of IMRT, which is called the BMAT, for almost most of 90% of our cervical cancers or even endometrial cancers are treated using that technique. And the other conceptual change is not only in radiation treatment, we also started treating the metastasis with a curative intent. Some 10 years or 20 years ago, the traditional teaching used to be the once the tumor has metastasized from the source, it would usually be considered in a palliative setup. But apparently what has happened is the biology of these squamous cell carcinomas of the cervical region and also quite a similar cancer like in head and neck cancer, squamous cell carcinoma, head and neck cancer, they don't usually metastasize fast. And even if they metastasize in a staggered fashion. So to say that the metastases do not kill the patient quickly. So in such a scenario, people have explored the option of even treating that so-called metastasis with a curative intent. So especially from cervix, we can expect the metastasis to go up to mediastinum nodes and lung. So what we have decided, what the community has decided is we explored some trials. Of course, there are no specific trials for cervical cancer alone, but it has been explored for colon rectum cancers that we can treat the metastasis either surgically, or if we do not want to remove the tumor surgically, we can go for what is called as an SBRT technique to shoot curative doses into the lung tumor, lung metastasis, or even to a mediastinal nodal metastasis. So this was one major conceptual change, which has changed our paradigm of thinking from palliative intent treatment to metastasis to radical curative intent treatment of metastasis. Of course, we need to define what is oligomets. That's an entirely different thing to go about. But for now, for easy understanding, we can say anything that counts up to 3 to 4 or max of 5 metastasis is considered oligomet, provided they don't compromise on the organ function very much. Like if they don't damage the lung enough, or if the liver is not, we don't land up in a liver failure with those metastases. So those are the scenarios where we'll think about curative intent using SBRT. So what's the next major change in our treatment technique is the use of MRI-based linear accelerator. So let me briefly go back to a picture where I showed our linear accelerator. So the linear accelerator, this upper part is the treatment head, which is called the gantry. It's got some wings on it. These wings are nothing but an inbuilt CT scanner onto the machine. So what we do is actually we do a CT scan of the patient every day and ensure that they are in the exact same position as day one. And then if they are moved up a little, then we try to use this couch to pull them back into the same position. We don't ask the patient to move. So because the patient is tied onto the couch with the cast, so we move this entire couch, which is computer control, and then bring them back to the same treatment position. So this is called as image guided radiation treatment, where we're using a CT image, inbuilt CT scanner into the machine to guide our position of the tumor and then treat. Of course, if you want to specifically visualize the tumor, then you can put in some radio opaque seeds into the tumor and then look at in the CT scan. Because this CT scanner is not as effective as a diagnostic CT scanner to look up all the margins of the tumor. So we can use a radio seed to better track the tumor. So that's a little way upward. So tracking the tumor while the radiation is going on, it's literally beyond the scope of this technique discussion. and we might discuss it for another session rather. So instead of using an CT scanner, so since CT scan doesn't show up very good image of the tissue, people started using MRI into it. So they built in an MRI right into the linear accelerator. Just like this CT wings, we had, of course, MRI doesn't come in wings, so it has to be a tube. So rather what they did is, instead of giving the radiation in a C-shaped arm like this, they started giving radiation in a tube-shaped machine like in an MRI. So that is where we call it as an MR linear accelerator. So we don't have a machine. So I'll just come back to this slide. So we don't have a machine, but technically it's almost similar to a tube-shaped linear accelerator. So maybe I can show it up in the picture at the end if you're interested. When I can pull up an internet image and show it up. So that is another new technology. So what has changed with this MR linear accelerator? So daily positioning and any errors in movement can be tracked much better than in a CT scan. So the image guidance which we are using to track the tumor every day becomes much better, especially if you are treating cervix with the differentially filled up bladder and rectum every day. The patient might be in a different level of bladder filling on each and every day. So this becomes tricky. So if the bladder fills up to 1 liter, it will push the whole cervical tumor posteriorly. But on day one, it would have been a bit in the midline position. So we would have, if you're assuming the tumor to be in the midline position, we'll be treating them wrongly. So that is why we need a CT scan every day or an MRI to improve this tracking business. And that thereby we can shoot exactly the tumor every day. If it was not for a multiple day treatments, if it was a 1 day treatment, we wouldn't have needed all this technology, because we on a single day we would have taken a CT scan and delivered it right on shot. But since the entire treatment is fractionated to avoid excessive toxicities, so we need to have different techniques to do that. So as of now, MR linear accelerator, and in fact, we had proposed to our institution, maybe in another 10 years, we might get the MR linear accelerator in our side. So this was about the external beam. So what we have also started using MRI in our routine brachytherapy procedures. So after you placing the applicator, we catch an MRI to see how much of tumor, what is the position of the needle and all those stuff. And we try to, this is where I talked about replacement of a point-based treatment with an MRI-based treatment. So if I can have the liberty to draw up certain thing, I just pick a pen and then I try to draw it, if you're okay with it. So let's say I'm just drawing you a rough diagram of a uterus in a vague position. And let's say I've placed in the tandem here, and I've placed in some ovoid boxes here. Traditionally, when we treat cervix, so let me pick another color here. So traditionally, when we treat cervix, in color of, let's pick the yellow. All right. So let's say this is the cervical tumor which we are trying to treat. So when we treat, we define certain points. These points were defined in the X-ray based era when we didn't use CT scan very much. So what people did at that time, so they had to calculate how much dose to go into this particular tube. So in order to calculate that, each and every patient had a different size tumor. Especially after EBRT, this whole thing could have shrunken down. This things could have shrunken down and the tumor would have shrunken on one side, or it could have grown onto this side on other side. So a lot of confusion of that. So let me just briefly take out this eraser. Yeah. So imagine after the external beam radiation is over, the tumor has shrunken and there's only 1 centimeter left out here. So if in the previous eras, when we are using only X-ray based treatment, since we did not use any imaging after EBRT, we went ahead with the blind treatment of using the applicators. So in order not to miss any position of the residual tumor, what we did is we took 2 centimeter away from the midline and then marked that as a point A. And of course, assuming this is an external loss, so we went 2 centimeter up and then 2 centimeter lateral to ensure this is the lateralmost point which we wanted to treat. So what has happened, so in order to treat this particular zone, assuming most of the patients whose tumor will lie in this zone after the EBRT is over, we had a blind point and were delivering the treatments. So now what has happened? So over the years, we started using CT scanners, right? So when we started using CT scanners, we have to put in the applicator and then take the MRI or a CT scan. I told you MRI brachytherapy has been practiced. So we can see the tissues very well delineated rather than when compared to a CT scan. We started looking at the tumor exactly the position depending on each and every patient's residual tumor. So if the tumor was only this side, So we don't have to shoot too much of radiation on the other side, right? So we only load certain isotope. We keep the isotope closer to this spot so that it covers only this particular tumor. So obviously these ovoids are going to shoot radiation a little around this zone. So this will help us to treat the entire cervical around this external os zone. So that's how it works. So this is what is called as volume-based treatment. So the point A, point B business is out of the, technically they're out of business. Now we have moved on to exact demarcating the tumor just like we did in external beam radiation, and we started shooting radiation like this. So this is what has changed in major trials which had involved a lot of Indian patients too, called as Embrace 1 and Embrace 2. So this sequence of 2 trials have defined MR-based brachytherapy tremendously. So, and that has changed most of our practice as well. All right, so let me just take off the air options now. All right. So coming back to other improvements. So since everybody talks about AI, what has happened, and since our department heavily is dependent heavily on major technological machines as well as softwares. So AI jumps into our field very much faster than many other fields. So what has done is as I told you, we were used to contouring, marking the tumors, right? So this marking business has been totally automated now. So you submit the CT scanner onto the software, it is going to do the entire contouring business for us. In fact, it has gone on to the extent of marking even the tumors, not only the organs, tumors as well. So our job technically reduces down to ensuring that whatever the AI software has missed out, we can just adjust it, and to best of our human knowledge, we can try to expand or limit the contours and volumes. So obviously the dose calculation part is also improved because all this involves machine calculation. So we submit it to the machine learning algorithms to calculate the best dose. So that is one major improvement in the technical advance of radiation technology. So when it comes to the new drugs, I told you with immunotherapy, especially in and around radiation, we were trying to explore areas, but there are no sensitizing immunotherapy drugs found yet, which can improve the killing effect of radiation. So until then, we'll only be using these immunotherapy drugs around the delivery of radiation. So in the adjuvant setting or in an adjuvant setting. So this is just to show you that if there is a lung metastasis, we have a heavy red zone only around the tumor and cooled light zones, blue zones. So technically, which means that the tumor is the one that is having very high doses, whereas remaining lung receives very less dose. So this is part of the SBRT treatment. So the machine which I have showed you before can also perform stereotactic body radiation treatment technique. So this uses all different angles. You can see traditionally we use only anterior angle, lateral angle, but here all these lines are different degrees through which the radiation can go in. So this is what we call as a volumetric arc technique, which is available in that machine, VMAT radiation. Of course, the names might be threatening to you, but don't bother about the names. We can stick to the meaning behind it. So the logic and the concept behind it. So with this technique, we can deliver radiation to the lung met, liver met, brain met, and any lymph nodes anywhere in the body. As long as I told you, the concept of oligomet is met, which is maximum of 5, and it should not have damaged the organ much to result in other issues. So this is MR guided brachytherapy. So the brachytherapy position, putting in the needles remain the same, concept remains the same. Instead of a CT, we are going to take an MRI to ensure that the precise tumor is identified and we don't have to shoot unnecessary radiation everywhere like we did it in the ester years. So we can precisely narrow down our zone of radiation, or sometimes it can even be a bigger volume. So we'll have to cover a larger volume than what is usually done in the traditional setting. All right. So I think with this, I have covered major aspect of it. So please move. I'm in an online meeting. So I'll just briefly cover this last slide. So with this, I will wrap up my discussion. So from a 2D era where we had used X-ray based treatment, we have moved on to a CT based treatment, which is 3D CT, and then we have come on to using IMRT and VMAT for most of the pelvic cancer treatments. You could say pelvic cancer, I mean that all the bladder, rectum, all the organs that are treated, including the genital organs. So in almost both the external radiation treatment as well as the brachytherapy treatment, we started using CT images, MRI images, or we also use PET images nowadays to precisely define where the residual tumor is and then shoot radiation only to that residual tumor and not blindly to everyone. Adaptive radiotherapy is one thing which we have not discussed much here, but the concept is, supposing if you have to do a 6-week treatment, after 3 weeks, the tumor has shrunk almost half in size. So we'll be unnecessarily irradiating because once it shrinks, it pulls down even the normal organ, like the bladder and rectum comes to fill that empty space. So if you are going with the initial size of, let's say, 5 centimeter of treatment volume, we'll be unnecessarily irradiating a lot of normal organs. So what we do is we redo the entire process of contouring and imaging again after the third week, and then continue the process. This is called adaptive radiation. So we change our target, the entire volume of treatment, to shrink the volumes as we proceed. Of course, the concept of metastatic disease, of treating them with palliative intent, has changed over to a curative intent, as long as they fit in the criteria of oligometastasis. And we are using more of software and artificial intelligence technique, which are nothing but the machine learning technologies. Since we are heavily image dependent, so AI has come as a rescuer for most of our tasks. So that helps us a lot. And finally, brachytherapy has become more precise from a point A and point B based era. We have moved on to an exact volume definition where we can define the volume and then treat the exact target. So that is it about, and thank you for the opportunity again. If there are any questions, I can take it.
Okay, bye.
Let me stop sharing it.
Your son wants us out as soon as possible, I think.
He doesn't know. Yeah, sorry for that interruption. I already
No
excused
problem.
myself.
We enjoyed.
No problem.
All right.
It was fantastic, Jagadeesan. Thank you so much. Others, comments, please. Any doubts?
Dr. Abraham wants to, sir, please say something. Sir wants to say
No,
something.
it was a fantastic presentation. Dr. Jagadeesan, you're a fantastic teacher. The concepts came out very clearly.
Very, very.
Yeah, no, when I was in Muscat, they had this MR Linac there. So, and they used to keep calling me for the brachytherapy, inserting the, to help them with that. Yeah, applicator, yeah. So, but, one old concept that, we do the radical hysterectomy where, and they require radiation. Does the dose given, of course, is reduced than usual? I mean,
Yes,
after
sir.
radical hysterectomy? And
Yeah,
also,
definitely.
do you always give brachytherapy in such situations? Because there was some concern that brachy might decrease to sexual problems in young women.
Yeah,
Could
I
you
think
comment on
we
that?
can conceptually, the logic tells us that when we are already removed the tumor, we should not give the same doses as possible. So radiobiologically, there is a term for that. So for every shot of 1 2 gray dose, the tumor gets killed. 66% of the tumor gets killed. 33% of the tumor remain. It might look a little awkward that with only single shot of 2 gray, when we expect 66, why do we need 30 fractions or 25 fractions? But if you look at the number of cells, the number of cells in a 1 cc volume of tumor is 10 to the power 9. So when you reduce 10 to the power 9, when you remove 66% of 10 to the power 9, what remains is 33% of 10 to the power 9. 10 to the power 9, 33% of 10 to the power 9 is 10 to the power 8. Right? So in logarithmic kills, it is nothing. It is actually nothing. But in our human sense, we think when we attribute to percentages, we think that we have reduced it with one single fraction, 33%. It has come down to 33%. So the idea is, our aim is to bring the 10 to the power 9 cell down to 10 to the power 1 or 10 to the power 0, which is usually one cell or a few hundred cells. So we expect the macrophages or the general immunity in our body to take care of the last few cells that are left out. So now when I mentioned 1 cc, we assume that is the residual tumor after a radical surgery is done. Because the idea of a relapse after a radical surgery comes up from these invisible tumor cells that are present in the body. So we assume, there are some scientists have to assume something. So we assume that all those microscopically invisible tumors can pile up to a 1 cc volume. So if you see a 10 cc or a 100 cc volume tumor before surgery, supposing if I'm taking up for a treatment without any surgery, I would be seeing usually a typical size is around 3 centimeter, 3 by 3 centimeter or 4 by 5 centimeter. These are the usual cervix sizes we see. A 4 by 4 by 4 centimeter tumor is nothing but 64 cc. 4 4s are 16 and 16 4s are 16. So 64 cc is 64 into 10 to the power 9. So this, if I have to do, I'll have to add, instead of 25 fractions, I'll have to add 5 more fractions extra to cover for that. That's what I mean. So we go for 30 fractions of dose instead of 25 fractions. But since we are using brachytherapy, what we do usually is we always reserve 25 fractions of EBRT, be it an post-op setting or be it a radical unoperated setting. That additional dose is usually adjusted in the brachytherapy setup. So we usually deliver 3 fractions of brachytherapy in an unoperated setting and only 2 fractions of brachytherapy for an operated setting. So this is how we adjust the dosage, and this is the logic behind it. So obviously we reduce the dose, so that is definitely an S. And if there is a risk, let's say there are high risk factors like a positive margin. So positive margin cannot be assumed to be that 10 to the power 9. It should be little more than that. So we obviously shoot more dose to the positive margin using the brachytherapy. All that adjustments are done at the brachytherapy level. As I told you, brachytherapy is hitting the tumor right in it. So there is no external component there. So we are able to precisely target. We can even put in an extra needle into that residual cut margin zone and then cover that with an extra dose. So that's the logic behind it. I hope I addressed that.
Yes,
That's great.
Jagdishan, one doubt. You said for our overall survival is around 64, around 65% for cervical cancers.
Yeah,
So
ma'am.
can
All
it,
stages put together.
all stages to it? Could it go up? Better survival, and if so, what are the factors which, not
Yeah, in fact, Dr. Veena had initiated a study where she was trying to find out HPV persistence. Can that be used as a predictor
yeah,
for the relapse? Basically to identify the poor
that's still
responders.
ongoing. Yeah.
Yeah. In the last 20 years, our job has been to improve this survival outcomes. But unfortunately, nothing has materialized because people have tried by adding chemotherapy after the entire radiation course is over. They added 6 cycles of chemo after the typical radiation course is over. But then that did not improve the survival yet.
And
Again, what they
outback
did,
trial, right?
yeah,
Jagdish,
there are
outback.
multiple trials. I don't specifically remember the names. I only
Yeah.
remember the logic behind it. I'm not good in remembering
Yeah.
those. Okay, so there are trials also in the neoadjuvant setting. So basically, we wanted to intensify the treatment and try to improve these outcomes. So, but the problem is, as I told you, 60% survival means only 40% are failing. So when you are trying to modify a treatment, all the 100% of the population is getting affected. So what we need to do is to identify who are the who are the ones who are having failures. So that prognostic biomarker definition is very important. And that biomarkers, we can use HPV persistence as a biomarker, or we can also use multiple special serum testing. In fact, there is something called SCC, immunological testing, squamous cell and carcinoma antigen. But nothing of that sort has been proven to be very useful in finding out who is going to fail and who is not going to fail. So we stick on to the traditional definitions of more than 4 centimeter size. Or in fact, I would what my feeling is, anybody who has a residual disease at the end of external beam radiation is going to definitely perform very poorly. Because many a times when we see, in fact, we see a lot of complete responses with just 25 fractions of external radiation. When they come on to brachytherapy, there will be only a residual puckering there. So that we come to easily identify those are good responders. So once they complete the course, they remain disease-free forever. But those who have a residual disease, large residual, even after completing 25 fractions, those are having poor outcomes. So how do we intensify the treatment is the next question. We can intensify by giving more radiation dose as much as the nearby bladder and rectum can tolerate, or by giving more drugs, by sensitizing the radiation with additional new drugs, or maybe during brachytherapy, we can add paclitaxel or cisplatin to enhance the effect of radiation killing in a much better way. But these are only exploratory approaches. The concurrent chemotherapy during brachytherapy was also tried, but unfortunately, it was not proven to be useful. So we are still missing on finding out exactly who is going to fail and who is not going to fail. Maybe once we catch it, then we will intensify. We have strong expectation from immunotherapy as well, because I told you the logic is you spoil the entire cell architecture and expose the antigens, and then use immunotherapy to boost the anti-cancer immunity of our body. So I hope that
There
could
is,
improve.
yeah.
Yeah.
There is
Yeah.
one in the chat box. If margin is HSIL bar LSIL positive, no other factor, is there any role for EBRT bar brachy?
Yeah, HSIL, LSIL are in a patient with invasive cancers. I don't think it should be considered as just an intraepithelial lesion, because once some part of the tumor, to begin with, it would have been an non-invasive lesion. But then it has turned up into invasive. That is when we jumped up and delivered our anti-cancer treatment. So those margins should still be considered as positive margin, and we'll have to deliver the residual doses. That is a usual practice in our setup. So
Do you
margin,
use? Sorry.
yes. No,
No,
whether the
this
margin
this
is PCIS or an LSIL or HASL, we'll still consider as a margin positive and deliver the dose. I think margin division is very difficult concept in pelvic cancers because in breast and other head and neck cancers, we do what is called as margin division. They go back and redo the surgery and then revise the margin. But I think that is technically difficult in our setup, in a pelvic setup, I suppose. Yes, sir.
Do you use immunotherapy for all patients or only those who are, after doing the CPS, the PD-1, L1 status?
So that we technically there are no schemes that can allow pembrolizumab in a setting. Even the CM schemes and other schemes, they give only 2 lakh or 3 lakh. So we don't use it for all patients. We only use it for those. I mean, we have not used it to enough number. Maybe 3 or 4 we have treated in this particular year. But we don't keep it. In fact, the trial in an adjuvant setting is not being proven yet. What was proven is only in advanced setting, residual and recurrent setting, which was what is published in that keynote trial, pembrolizumab in an advanced cervical cancer. So that is where we use pembrolizumab. We don't use it in an adjuvant setting in any of the patients.
Annapurna, you can ask your question yourself. Annapurna belongs to batch of 1989 and PG batch of 1995. I think she's there.
She's
Anna? Yeah.
consultant in Shankara Cancer Institute in
no,
Bangalore.
that's more important.
Okay. Hi. It was nice.
Hi, ma'am.
And I just want to know whether you guys are using immunotherapy with RT. Because here
Concurrent,
also
no,
the
ma'am.
same problem, actually, the same problem here also for advanced cases or metastatic cases. But for metastatic cases, we have had fantastic responses with Pembro. But are you using with RT also?
No, ma'am. For none of the pelvic malignancies, we are using immunotherapy in a concurrent setup. We don't use concurrent setup. We are not done that yet because we don't have enough data on any of the concurrent utilization. Although the cancer biology tells us we can
Yes,
effectively
it
use
makes
it.
sense.
But if you see all the other cancers, most of the cancers, it has been immunotherapy produces impeccable results right after RT. I mean, you deliver immunotherapy right after the completion of EBRT, then it produces good response because that is where I think for the best example is lung cancer. Durvalumab added in a setting after the radical CTRT is over improves the survival much more than a year. So it is the disease survival is very much prolonged, and it's also proven in esophageal cancers. Unfortunately, or maybe we might have to initiate a trial on that to see the effect of that. So the answer is we don't practice any concurrent immunotherapy yet, and we are also not practicing adjuvant immunotherapy in cervical cancers. Only in advanced setup we have tried.
There's another question, Jagadeesan, in the chat.
Question or comment?
No. Minimal tumor-free margin in vaginal cuff. What is what exactly is a tumor-free margin you're looking for to call it as tumor-free margin?
In head and neck cancers, in head and neck cancers, we have a concept of close margin. Although the margin is negative, we'll say if it is very close, let's say within 5 mm, we will think that is a high risk factor. But in genital cancers, we do not have a definition of a close margin. So if the margin is negative, the margin negativity is defined by the pathologist as at least 1 millimeter of ink-free zone. 1 millimeter of ink-free zone. That is what is defined by the pathologist. Maybe their definitions have changed, but this is what I had understood from them. So if there is 1 millimeter of disease-free margin, we'll technically call it as a tumor. It's a negative margin. So we don't define any close margin as of yet, and we don't have studies. Maybe in vulval cancer, there are a lot of retrospective studies where they have compared. Because vulval cancer, by definition, is a very aggressive cancer. So there they have used the depth of invasion margins. So there it has been found that depth of invasion more than 5 mm or even the cut resection margin less than 1 centimeters, if it is not done, they have a higher chance of relapse. So, but in cervical cancers and especially in vaginal cancers, if you have a negative cut margin, vaginal cuff margin, that is taken as negative.
Okay.
Are you using any intraoperative radiation therapy?
No, sir, we don't have the facility yet. We are getting a building coming up. So maybe once the surgical oncologists come into our building, we will try to.
Any oncologists?
I'm sorry. I mean, but the building was for surgical oncologists. So I meant that OT with the intraoperative setup. But if your department can allow us intraoperative machine into your OTs, then we will definitely start it.
Once all the 6
Sure,
OTs
sure.
start, we will
Yeah.
definitely.
Yeah. Jagdishan, I have one more basic doubt. Have you seen major difference between the patients who get primary RT and those who get following a laparotomy, like post-op RT? Like any morbidity, like ureteric morbidity or enteric morbidity is really higher? That's a theoretical concern, or are you really seeing that?
You're talking about cervix, endometrium, and all put together, or any post-operative setup versus a non-operative
Because
setup.
basically in cervix, because there we don't do radical if we think that her chance of getting radiation is higher, right? So because all the morbidities will increase is one of the
I
concerns.
mean, this was actually true. It is even true now, but the difference has narrowed down. Primarily because I told you, 95% of 90 to 95% we have moved on to a VMAT or IMRT based treatment. So when we start to do the IMRT based treatment, in one of the slides I have shown you how the bowel component peritoneal space is defined. So when we define it and let the computer do the calculations, we will be getting a optimum direction through which we can avoid the bowels.
Okay.
But the problem in the unique problem in a post-operative setup is, supposing if it was an unoperated setting, the mere presence of uterus pushes the small bowels out of the pelvis, or maybe the distension of the bladder and the rectum. In a post-operative setup, you don't have the big bulk of uterus there, uterine body there. So that space is going to be filled up naturally with the small bowel.
Yes.
So even though you have the best technique, when you have the bowel sitting right on top of the vault, it's technically difficult to slow it off. Then we'll have to explore a reverse Trendelenburg position in radiation treatment, which nobody has explored yet.
Actually, Habib sir used to teach us 20 years back when we were PGs that post radical hysterectomy, there's a huge raw area over there, and bowel may get adherent. So
Yeah, that
bowel
is also
which is actually a mobile organ, like due to peristalsis. A constant portion of bowel will receive continuous radiation, and the enteric morbidity like stenosis or
that's exactly true. That's
are
because
you
the
seeing
empty
in
space is
practical
out.
setting? I mean, this is what I also teach because my teachers taught me that. But is it really? Do you really see any difference in practice?
In a post-operative image, when you do the simulation, when we do the contouring, we see the bowel stuck there, and we have practically no way to push the bowels out. In fact, the idea of vaginal packing in an intracavitary setup is to push the rectum. It's to push the rectum down. So, but we have no way of packing to push the small bowel out of the zone. So that unless we have let's say a surgeon puts a tie and then keeps the loop up and then lets the patient during in fact, transposition of ovaries, we do the transposition of ovaries exactly for this reason.
Yes.
But you can't do that for bowel.
Bowel we can't do that.
We don't know. Nobody has explored it, but then it's an extra hefty job, right? Somebody has to
you can put a mesh, I suppose.
So,
something to hold on to, not let the bowels fall into the pelvis.
Sometimes after exenteration, we put a mesh to keep the bowels coming right down. So we suppose you could do that. But, yes, the difference has definitely reduced with the newer techniques.
Volume.
But still, bowel can get stuck there.
Yeah, when you have a bowel right inside closer to the target, no advanced technique can reduce the dose technically. Very difficult.
Some participants have raised their hands. Is there anything to ask? They can ask.
Sir,
Ananya,
this
yes.
is good evening.
Yeah, Ananya, go ahead.
Sir, I had one doubt. Actually, we had a patient who had CA cervix and then she received EBRT for the same, but she also had a huge irreducible prolapse and she had come with it. Initially, we started reducing it. We put label stitches. She was sent for brachytherapy, but the prolapse was so huge, it used to come back and she used to keep coming back. So in such cases, if we use IMRT or does it still necessitate brachy or she can wait, because the treatment time from EBRT to brachy was prolonged because of the prolapse. So
what we usually do in that setting, prolapse is quite a common scenario, especially in fact, prolapse is one of the causes for prolonged exposure that turns up into cancer. Most of the time, I think it's usually a good type of cancer in the sense that it's exophytic in nature. So that is why it is getting prolapsed. So we don't exactly define what is the cause and what is the effect. But what happens usually is our aim is to cover the entire tumor volume. So to cover the tumor volume, if it is reducible, there is no issue. Put a stitch in it, let the tumor stay inside the vagina, and we treat it in a traditional fashion. If it is not reducing in, if it's not going in, then what we do is we'll have to let the tumor stay outside, and then we'll still contour the entire volume and then shoot radiation to the pelvis, including the tumor that is projecting out of it. So what is going to happen is a little bit of the thighs are also going to get treated along with it, unless we change the position to a little abducted part. I mean, when we move away from the standard positioning, it's very difficult. So unless it is done in a trial setting, we cannot do that individually. So what we do is we'll again stick with only the thighs adducted position. So obviously medial part of the thighs are going to be exposed. So this EBRT, once the EBRT course is, maybe during the EBRT course, I was giving you an idea of adaptive RT. After, let's say, 2 weeks of radiation, if the tumor gets a little reduced, allowing us to push the prolapse in, that is a good scenario for us to proceed further with the stitch, labial stitch at 2 or 3rd week. If it is staying outside for the entire course, there is no other way. We'll still go ahead with the radiation, but the entire bladder is going to get all the dose because there's no way of preserving the bladder. Bladder is going to sit right anterior to the tumor, and in an external, when the tumor is out, it will pull the bladder out, bladder in the anterior part as well as part of the rectum. All those prolapses also can happen. So reducing doses to the bladder and rectum becomes a challenge. So we will expect high cystitis and proctitis in those patients. That's the only scenario. So the other option is, if it is resectable, a surgical option has to be attempted because these tumors don't have a parametrial invasion. Because most of the tumor comes out, they'll usually stick to the vagina and it won't go into the parametrium. So these are the two options. This is what we do now.
Okay,
When
thank
you
you.
talk of SBRT, is it stereotactic, or is it interstitial, or are you trying to focus the external beam?
It's stereotactic external body radiation treatment. So it applies to only external treatments.
External.
Because brachytherapy by nature is a targeted, highly precisely targeted treatment. We are pushing the needle right into the target. So we don't need any more technique other than this. This is actually the highest form of targeted treatment.
Right.
So SBRT applies to only external treatment. In fact, SBRT is specifically labeled when we are trying to use some additional 3-dimensional techniques to define the position. So let's say we put in a radioactive seed into the target. And as I said, we have that extra CT wings on the linear accelerator. So every day when we position the patient, we can shoot a CT image and then precisely define. Rather than defining it in the CT image, we can only merely track the radioactive seed. You place it in such an 3-4 dimensions so that you cover the entire tumor with it. So we'll stop looking at the tumor on every day. We'll only look at the radioactive seed every day and try to match it. Once we match it, it becomes a highly precise target. So we with an error rate of even 2 to 3 millimeters alone. So that is what we call a stereotaxy. But this can be achieved with very other means, of course, sir.
Thank you.
There's another question in the chat box, Jagadeesan. What's the response of if tumor more than 2 centimeters is left behind after reaching EBRT?
More than 2 centimeter, as I told you, it's a very, that's lot of residual disease are there. So in an older era where we defined the 0.8 dose, we would go with the typical 0.8 prescription, and this tumor would have come back with the residual disease at the end of treatment. But as I told you, we do a CT scan now, so we do not stop the treatment in between, even if it has crosses the 2 centimeter border, because another 30 gray of effective dose is still pending in the brachytherapy setting. We only delivered 25 fraction of 50 gray.
Yes.
So we will deliver almost 30 to 40 gray equivalently. So which means almost 40% of the dose is pending. So we will contour that and then try to accommodate in the traditional intracavitary brachy. If it doesn't accommodate, we will have to put in the extra needles on the lateral side.
Interstitial kind of thing.
Yeah. So interstitial, it will be combo of interstitial as well as intracavitary.
Right.
But we have different applicators for that. We can have different names.
Yeah.
That is what is
Jagadeesan,
intended.
I
Yeah.
have one very, very, very basic doubt. So
Yeah.
whenever you're giving the radiation, EBRT, whatever, 2 gray per day, is it the same irrespective of the tumor volume?
You mean the dose per fraction every day?
Yeah, yeah.
Yeah. The dose per fraction can be varied from 1.8 gray per fraction to 2.2 gray per fraction, which we still call it as a conventional fractionation. In our daily the VMAT technique, which I said, we can deliver any of this range of doses per fraction. We'll still call it as 2 gray per fraction for conversation's sake, because the effect doesn't vary a lot. But when it goes to more than 2.2, let's say 2.5 gray per fraction, then the effect is slightly enhanced. You mean you start getting more killing per dose than what we expect in a 2 gray per dose. So, and that along with that comes in more toxicities as well. Because if it was so good, then all of us would have moved on to 2.5 or 3 gray per fraction. But there are some subtle issues. Higher dose per fraction results in high toxicity. The high toxicity in the sense here we are looking at cystitis, enteritis, and proctitis. So these are the 3 things that will escalate. In fact, there was one recent publication in Red Journal from Lucknow, RML Lucknow, one of my colleague during my residency period. Dr. Ajit had done a study. He had done 2.5 gray per fraction. So the treatment, instead of running on 5 weeks, he was able to shrink it down to 3 weeks. So of course, he used VMAT, IMRT technique for all the patients to reduce the toxicity and all those. So he was able to complete the entire duration in external radiation in 3 weeks. Subsequently, the overall treatment time also comes down. So this reduces the patient stay. Many other benefits are also there beyond the tumor effects and other effects. So that is one useful study we'll have to follow. Maybe we can also try to do that. I initiated a study in the form of a thesis some 2-3 years ago. But repeatedly, the candidate who comes on to my student, he discontinues the course and goes. This happened thrice.
You can,
So I thought there is
you
probably
can
some
give the
taboo.
PDF candidate now.
There's probably some taboo on that trial, so I just shelved the trial option.
Now that we
Jagdish, I
have
have
PDF, yeah.
Yes, sir.
Jagdish, I have a few doubts.
Yes, sir. Go
The
ahead, sir.
whole RT should be finished in 8 weeks, isn't it?
Yes, sir. As short as possible, but the definition of 56 days, 8 weeks technically.
That's right.
With the hypofractionation, whether it's 2.25 gray or 5 gray per fraction, we can shrink it down to a little lesser. But then the lesser you make it, the more toxic it becomes.
Okay.
So
And
we'll have to be. Yeah.
another thing is for hemostasis, hemostatic RT, how
Yes,
much
sir.
brachy or the EB you will give?
So for hemostasis, the best is put in a brachytherapy thing and then shoot radiation, right? Because brachytherapy is quite precise. We don't have to come to external routes. So we will give 6 gray to 8 gray in one single shot.
Okay.
But the problem is if it was usually it bleeds only when it's a very large tumor, because small tumor bleeding can be controlled.
Yeah.
But if it's a very large tumor, it won't allow the placement of even the applicators. The entire vaginal cavity might be filled up.
Okay.
So invariably we go with an external radiation. We will usually give around 3 gray per fraction, sir. There we give the hypofractionation. We give almost some 5 fractions of 3 gray per fraction. With that, usually the bleeding gets controlled. And then we switch back to 2 gray per fraction in the traditional sense.
Okay.
Obviously, we expect more toxicities, but then toxicity is better than having a continuous bleed. So this scenario, it outweighs the benefit. I mean, the risk.
Okay. Thank you.
One more question is that can we pull down the omentum down to the wall to cover raw area after radical?
Maybe I can answer that.
Yes, sir.
Yeah, I mean, the omental J-plasty, sometimes we do it, but we'll have to release the omentum and then, leave it attached at only one corner. But then for that, we'll have to extend the incision up well above the umbilicus. So that's the only problem.
But how much will it prevent the
No, it'll
radiation
come.
effects?
If you release it from the greater curvature and leave it only at the top, attached only at the top on the left gastroepiploic, then we can bring it down. So that is also one way of filling the pelvis.
That may prevent bowel getting attached to the vault, but
Yes.
it can still get attached to the abdominal wall, abdominal incision, peritoneum incision site.
Everybody.
In fact, I think this will help us. In fact, if we are able to hold the bowels and not let it fall into the pelvis, we can think of that hypofractionated schedule in a post-op setting. Because the problem with hypofractionated setting is, hypofractionated I mean is giving more dose per fraction and completing the entire dose in a shorter period. The problem with that is this bowel toxicity, because we are not able to raise the dose high up. So when we can handle the bowel, we can even shorten the course and then try to deliver as fast as we can. Because the amount of effort we put in, surgeons and everyone, so we can also try to shorten up the treatment in that.
Another simple thing is when you are giving this radiation, will Trendelenburg help? Because of course, if it has got attached, if it has happened within 3 weeks, then we can't help it.
I don't know, ma'am. Whether Trendelenburg, we'll have to literally keep them upside down for the bowel to go up, I suppose. Trendelenburg, I don't know how much.
Not much, but yeah, if it has already got stuck
you,
during surgery,
you
it's
won't
difficult.
start RT immediately.
Yeah,
By the
immediately.
time reports come, wound
True,
healing
true.
and all that, you'll start late.
Yes.
By then, adhesion would have formed.
Yeah, that's what. Yeah.
If it has not formed, it won't form.
Yes.
That is the time it gets formed.
About hyperfractionation, you said it was not useful or it's too toxic. Hyperfractionation.
Sir, hyperfractionation was not tried. It was tried in lung cancer and it is proven to be useful, especially in small cell carcinoma of lung. But the major practical problem is giving 2 fractions per day will increase the number of patient treatments per day. If you are treating 60 patients in a machine in a
Right,
day,
right.
now we'll have to treat 120 times the same
Okay.
patient, right? So that technically burdens the department a lot.
Department.
They
That is why
already are
universally,
working till 8 in the night.
yeah, ma'am, but yeah, of course, because we are paying literally almost 1 crore per year for only maintenance charges. So we need to justify all the costs. So we need to run the machine as much as possible. So that is one. So universally, this hyperfractionation has not been preferred because of this. In fact, Westerners will be
So
more of
logistic, yeah.
weekend guys, so they don't want to spoil their fun in the weekend.
So one more thing I was thinking of, interseed causes, decreases the adhesions. Maybe routinely, if we put interseed on the vault, maybe to some extent, the draw area and bowel may, we can prevent the bowel from getting adherent. I don't know.
Yeah, previously we used to close the peritoneum. Now we are not closing peritoneum also.
Pelvic peritoneum, that's true.